Hello, everyone, and welcome to today's webinar, COVID-19 and Your Radiology Practice. Before we get started, I'd like to go over a few items so you know how to participate in this webinar. You've joined the presentation listening through your computer speaker system by default, or maybe even a mobile device. If you prefer to join audio over the phone, just go over to the audio section in your control panel and select phone call, and the dial-in information will be displayed. Vice versa, if you've joined over the phone and you're having trouble, you can always join audio through your computer and just select computer audio in that section. You can submit text questions to our panelists today. Just type them into the questions box in your control panel and we'll address them at the end. I would now like to introduce today's moderator, Ruth Carlos, Editor-in-Chief of the JACR. Welcome, Dr. Carlos.
Thank you. And welcome to all the folks who are listening and watching with us virtually. This is the JACR webinar with a panel of individuals who represent the diversity of our practice in radiology, and will be sharing the breadth of their experience as we try to navigate the current situation and the crisis after the crisis. Because COVID-19 is a rapidly evolving situation, the material presented today reflect the best available evidence and knowledge and may need to be updated as more information becomes available. We have a broad range of speakers, including private practice physicians, a chief medical officer of a critical access hospital, and academic leaders. We will start with Dr. Samir Rowe. Next slide. Dr. Rowe is Chief Medical Officer of Jamaica Flushing Hospital Medical Centers in New York and represents a critical access hospital. Next slide. Dr. Rowe, I'll turn it over to you.
Good evening, everyone. I am the Chief Medical Officer for Medicis Health Network in Queens, New York. So we have two safety net hospitals in Queens, Jamaica Hospital and Flushing Hospital. We serve a very diverse and challenging patient population. About 80% of our patients are on government pay, 60% Medicaid, 20% Medicare, and we have a high number of uninsured and undocumented patients. Just to give you a magnitude of the diversity of our patients, we serve a patient population that speak 135 languages. As you all know, Queens is the epicenter of this whole COVID crisis. So currently in our hospitals, we have about 500 positive COVID cases plus another 100 PUIs. And today we had 140 ventilated patients in the two hospitals. So the crisis started in the first week of March, and we started seeing patients. 3rd of March was the first patient when we came, and after that there was a significant increase with the numbers doubling and tripling as the days went on. A little bit about our practice. So my radiology group is a group of 22 radiologists that serve both Jamaica and Flushing hospitals. It is a hospital employed group. Next slide, please. So I will just go over, because I haven't had time to do all the slides, so I will just go over what we have done within our own group. Some of my radiologists have the capability of reading from home, and we have been rotating them so we can keep some of them out of the hospital and healthy while the rest of them come to work. We have some radiologists who have young kids, and their need was, because the schools are closed, their need was to stay at home, and we have done that. They come to the hospital only when inpatient procedures are needed. So at this time, we have not had a need to rotate our radiologists in other departments or other services. However, my interventional radiologists are aware that there may be a point and time when they may have to cover either the ER or they may have to go up on the floors. I also happen to have a radiologist who is boarded in internal medicine as well, and he is prepared to be on the floors when need be. As far as the rest of the department, our technologists and nurses, we have changed their shifts to 12-hour shifts. We do give them a break of a day or two during the week just to recuperate and come back. As many of you have also experienced, there has been a significant increase in the number of portable x-rays that we are doing. That is the biggest stress on the department these days. So we have utilized techs from other areas, from MRI and CT, to help our x-ray techs when they're going up on the floors, to help them with the portables. So that is the biggest need. We did also see a significant increase in the number of ultrasounds that were coming through. Many of these were for elevated LFTs and because of acute renal failure. So after discussions with the department chiefs, we were able to see which ones are really indicated and cut down on the number of portable ultrasounds that were being requested. As far as the elective procedures, the whole hospital has really cut down all elective procedures, and so has radiology. The way we have done it is all the procedures that were scheduled for this month and the coming months, all those procedures were reviewed with the radiologist. The radiologist then instructed our file room people which of these studies need to be canceled. The file room people called into the referring physicians. If they have any questions or concerns, then they speak with the radiologist, and all urgent and emergent cases are performed. As far as mammograms, we have canceled screening mammograms. We have continued to perform the diagnostic mammograms that were pending. Our surgeons also have continued to do the stereotactic biopsies that are pending for the patients and ultrasound-guided biopsies. Rest, all the procedures are canceled. Our interventional radiologists are doing the inpatient procedures. They have also helped out with the PICC line insertions because that was being done by PICC line nurses who are now pulled to provide care in other areas of the hospital. Talking about the downstream demand, we really haven't gotten to that point. We're in the middle of the crisis where we are only trying to take care of what is happening now. We do talk about what the new normal is going to be after this crisis is over, but to tell you the truth, we haven't had time to think about that at this time. As the Chief Medical Officer of the system, much of my time is really spent on taking care of issues hospital-wide, actually network-wide. We do have the 2 hospitals, but we also have a very large ambulatory care network. So when this crisis started, we got a mandate from Governor Cuomo here in New York that every hospital has to increase capacity by about 100%. The need for critical care beds has been significant, so we have significantly expanded our critical care beds into surgical ICU, into ASU, into PACU, cardiovascular catheterization recovery area. We have moved patients from PEDS patients from one hospital to open up PEDS floors. We have moved OB patients from one hospital to open up OB floors. The staffing has become another issue because many of our ER physicians and our residents are getting sick. Our nurses are getting sick. So that has been a big strain. So now we have surgeons and orthopedic surgeons and general surgeons covering one of the ERs in addition to the few ER physicians that are left. We have the surgeons, they have started a central line service for the medical residents. Our ambulatory physicians have now started covering inpatient floors. Our anesthesiologists are providing intubation service for all the inpatient floors. So it's been a significant stress, especially for our critical care physicians who have been working 7 days a week for the last 5 weeks. Luckily, we have some volunteer organizations that are helping us with physicians, and I'm working with the American College of Chest Physicians who have been providing me now with volunteer intensivists who will provide some relief for our patients. So it's a struggle day by day, trying to get staffing, trying to cover the areas, trying to have enough ventilators in the hospital, trying to have enough supplies, because we literally have doubled the volume of patients we are seeing in our hospitals today. So the other thing that we did is last week, my CEO and I were discussing, we were at a point where we had 130 ventilators running in the 2 hospitals, and the capacity was beyond what we could handle. So knowing that most of the hospitals in this area in New York were stressed, we did not know where to look for help. So what we decided was we called some of our colleagues over in Albany, knowing that Albany has a very efficient transfer service. So we called Albany and we had a transfer agreement with them. And since last week, we have transported 115 patients to Albany. About 55 of those were on ventilators. And it has at least helped us de-stress a little bit the 2 hospitals. So we continue to move patients to Albany. We continue to provide, open up new areas in the hospital to deal with this increased volume of patients that continues to come. So that's been my story for the last 5 weeks.
Dr. Ralph, thank you so much for sharing your experience from the epicenter of the infection. Next slide. Our next speaker is Dr. Samir Patel from Beacon Health System. He is a private practice radiologist practicing in North Central Indiana. Dr. Patel, you're up.
Thank you so much, Dr. Carlos. Thank you, everyone, for joining this late afternoon and this evening. So my practice has been in existence since 1904 and was around at the time of the 1918 pandemic that occurred. More recently, we were involved in a local epidemic in 2012 related to fungal meningitis, where we needed to consult the CDC, and I was chair of the department at that time. So definitely recent past experiences have helped us with this current challenge. I am part of an independent private practice radiology group, diagnostic and interventional radiologists near the South Bend region. Approximately 5% of our patients are COVID positive in our largest health system. Our practice size is about 39 radiologists, and we have a combination of both multi-specialists and subspecialists. We also have our own billing operations and staff. And so our responsibilities are not only to the patients, but to our business and our employees. And several of our members are on health system boards, and so we have responsibilities at that level also. Next slide, please. So with regards to workforce deployment, leadership is really critical, and we've learned this with our last epidemic that occurred, and having a strong chain of command is quite essential. We have a human resources committee, but really the department chairs and the vice chairs of the hospitals that we cover, and we cover multiple hospitals, which is also a challenge because each has their own individual timeline for when they implement their responses to COVID. We also have some home workstations. Our practice was primarily an on-site presence. We demonstrate a lot of value and are involved in a lot of leadership activities. And so we do have several workstations that are available for individual radiologists in our practice that either themselves have risk factors or they have family members that have risk factors. And we also have several backup workstations for those who may be quarantined. And we coordinate that with our own practice network engineers in our practice, interfacing with the hospital IT associates. Next, please. So engagement with client leadership on rescheduling exams has really been the driving force for us to modify our supply as far as our staffing is concerned. And so we not only work with leadership at the departmental level, but also at the hospital level, at a C-suite level, and then also at a board level. And so the adjusting of the demands, canceling non-elective cases, really then drives our staffing. Next, please. Next, please. And so by covering multiple different sites, we block schedule not only radiologists, but also by service lines. And we try to minimize multiple radiologists ever being involved in a single reading room. And so we've batched our radiologists' workflows such that they're pretty much going to be doing the same types of daily activities for pretty much a week on end. We also tend to have reading room switches sometimes, where a person might be in one reading room for the morning, different one in the afternoon, and we've done to eliminate that. Next, please. And next, please. And a couple things that we've done is we have completed an internal practice and health system surveys about us going outside of the department. Next, please. And so cross-discipline coverage for us could mean several things. We do have breast imagers that will do general imaging, and also we have filled out surveys for doing cross-service lines, ER and that, but we have not implemented that yet. Certain leadership positions and assisting with the technologies are also things that we're doing as far as from a cross-discipline standpoint. And us being multi-specialists has really helped us out in this endeavor. Next, please. So with regards to elective exam rescheduling, again, we do cover multiple sites, and that has been quite the challenge. And the variability has been really across the oncology spectrum, and also with regards to surgeries and other things, because not every site is synchronous. And so what really is key is whatever the particular client has, we want to make sure our practice members know what is going on there. We can advise the leadership there, but again, that has been an ongoing challenge. But communication with the leadership and also practice members is critical. Paralleling what we do with the health systems is also critical. So we're not either performing things or not performing things that the system is not doing for other things. And following an incident command structure with radiology being involved at the department level all the way up to the board is essentially critical. Next items. And in oftentimes of crisis, you may have multiple voices, but this is where we really rely on our chairs and vice chairs for policy input and external communications. Our sort of involvement with COVID really started around the middle of March, and at our largest health system, next items, we indefinitely have suspended screening mammograms and basically elective cases. Our IRs part of the follow surgical policies, and we really try to mimic what the hospital is doing for other sites. But again, scheduling, we're on constantly, not only talking with the technologists, but also providing guidance to centralized scheduling. Next slide. Next, please. So what about downstream? And so sort of the, not so much the now, but the near. So the near is our practice model over the last several decades is we have what are called flex days, where they're not guaranteed, but essentially we made the decision several decades ago that we would sacrifice some amount of income to have flexibility for work-life balance, so we can adapt to volume increases and if people get quarantined. Next, please. And next items. The other thing is we increase our staffing towards the tail end of the year, and what we're thinking about doing is if we do sort of come out of this and we start to see increase in volumes, we will just up the timeline for that implementation. We also will offer internal moonlighting in the future if we need to. So for those that want to work more, we will compensate them more, either through working extra weekends or even selling vacation days. Next slide, please. And next slide. So one of the things is, as we focus on the near and the far, is we do have new recruits coming in, and that will definitely, we're looking forward to them coming in, so they will also provide additional information related to that. As far as decreased revenue, our business office has been indispensable. We monitor our cash flow projections, and those are reported to our executive board. We do utilize an internal method to monitor our cash flow, but there are commercially available things, and here's a link that's present. Next items, please. We are currently withholding bonus payments to our shareholders. However, we are currently preserving our staff salaries, and our business staff is continuing to work from home. Next items, please. We were utilizing a teleradiology service, but now we have taken it in-house. It's primarily been a value add. Secondarily, the financial benefit. And then the three items that we have currently done, we have applied for the payroll protection program. We have just submitted information for the Medicare Advance Payment Program yesterday, and we're waiting on details on the Public Health and Social Services Emergency Fund. We are cognizant of our patients, And one of the things is the ACR provides great resources, so we're constantly monitoring those. Next, please. And that has been our experience. And so definitely don't forget the past, look at the near and the far, but definitely be well, be resilient. Thank you.
Thank you, Dr. Patel. Our next speaker is Dr. Robert Pyatt, Chair of WellSpan Summit Health. Dr. Pyatt.
Thank you, Ruth, and good evening, everyone. I'm in a private practice small group in central Pennsylvania, covering about 175,000 people. You can see my sketch there. Next slide, please. So although we have a number of subspecialty trained rads in the group, which you can see outlined at 3 neuro fellows, a thoracic fellow, a body IR fellow, and an MSK fellow, all of these subspecialty trained fellows, fortunately, spend greater than 50% of their time outside of their subspecialty, so it helps us a great deal. And then we have 5 other rads who are not fellowship trained, but are broad spectrum, strong generalists. So relative to covering things during this crisis, we're doing pretty well. We haven't really had to change a lot from what we normally do throughout a regular non-COVID week. We've also seen a sharp decline in our volume, like most of you have seen, and including overnight telerad use as well. So we've seen quite a decrease in that as well. All of the full-time rads prior to this issue with COVID, all of them have been equipped with home PAC stations, which we're very happy about having that already in place and which are used quite a bit. We're trying to limit the amount of risk that our colleagues are taking. So basically, we bunch our procedures pretty much in the morning in the hospital as much as possible. And instead of that rad spending the whole day in the hospital, that rad is able to do all the procedures. And once that's done and completed, usually around lunchtime, they're able to then go home and read by telerad for the rest of the day. We also have, of course, decreased significant amounts of procedures that were elective. And then we also have maintained our outpatients at one of our outpatient centers. Several of them are closed. But this outpatient center is where we do our diagnostic mammograms, stereotactic biopsies, ultrasound biopsies, and non-COVID patients. There's an open-air tent with that facility that screens a lot of patients, and none of them come into that outpatient center, however. And then relative to our part-time staff, as you noticed from the first slide, we have full-time and a number of part-time staff. So we have the part-time staff basically either on vacation, temporary leave, and some of them transferred future vacation weeks to this period of time, so it's considered vacation for them. And we're speaking with them about, when all of this is over, we do anticipate some sort of a rebound, which I'll talk about in a moment. Next slide, please. So all elective or non-acute cases have been rescheduled, and they've been pushed back to the week of May 4th. We've had a system-wide throughout all of WellSpan being a system covering about 1 million people here in central Pennsylvania, but we've had a uniform process that the radiologists have developed throughout the whole system. Today, the Pennsylvania governor announced that the stay-at-home deadline of April 30th may change, and I don't know how many of you are hearing about that, but it appears that the stay-at-home date, at least here in Pennsylvania, may be moved, and I'm hearing various predictions that it will be pushed back possibly to as late as May, end of May. So, but overall, we've had a decline of about 2/3 of our cases, all of which are elective, and various cases that could be pushed back, and we're doing about 1/3 of our normal volume. We do anticipate a heavy workload once we get back to the normal routine after this, which we had thought was going to be May 4th, but what I'm hearing today is that we may be extending the stay-at-home date and so forth for several more weeks. Several of our outpatient centers, which have imaging, have closed during the crisis, and some of them have been converted to strictly for COVID testing with outside open-air tents. And the urgent care centers that we have in our system are being converted for housing COVID-positive patients, which is during the anticipated surge later this month and well into May. based on new information and projections. Fortunately, these urgent care centers, we have a number of them, and they're coming in very handy for this anticipated surge. Next slide, please. Part-time rads who are temporarily not working or on vacation are being notified that we may need them heavily for the rebound later after this is over. And with the month of May is already, I understand, heavily booked with not a whole lot of open slots, but we may well be looking into the beginning and mid-portion of May and push that back into June the way it's sounding today. So, and I imagine this is going to be happening in other places from what I'm hearing about the projections that are being modified around the country. Next slide. We have applied, like was mentioned by Samir Patel a moment ago, for these loans and grants related to the CARES Act, and we are waiting to hear back on that relative to the Payroll Protection Act. Our bonuses, which ordinarily are distributed at the beginning of the second quarter, were not distributed. We purposely held them back, and we're going to keep that extra cash to help pay for operational expenses. All of the partners in the group are having a significant base pay reductions, and we've also been alerted that we may even actually have no paychecks at some time. So we're just all being alerted for that. However, this the CARES Act, we hope, will help us through that with our billing staff. We also have our own billing operation with our staff on. Nobody's been laid off, and everybody is working as best as they can, either at the office or from home. We also are looking into, we have just started this week, increasing our coverage of the nighttime hours to try and take back from some of the telerad that we used to send out. And we've also eliminated moonlighters who used to help us on weekends for April and May. We have fixed expenses that we're, of course, required to pay. We are looking at a revenue rebound after all this is over. And we're projecting a trough for receipts in our billing, deepest from mid-May to mid-June. But with the new projections, this may be modified into early July. And also, the part-time rads are not applying for unemployment. Thank you.
Thank you, Dr. Pyatt. Next slide. Our next speaker is Dr. David Kirsch, also in private practice. Dr. Kirsch.
Hi, this is David Kirsch. It's an honor to participate in this timely webinar. I'm a private practice radiologist, subspecialty in interventional radiology with Southern Radiology Consultants, which was formerly Baton Rouge Radiology Group in Louisiana. We have about 40 or more contracts scattered throughout Louisiana and Mississippi. We have 17 partnered radiologists and a couple of partnership tracks. We are predominantly partnership within the group. We have employed some part-time radiologists through the group in the past. Next slide. So one of the first things, as far as the workforce deployment and preparedness, the initial reaction of the group was to flee the hospitals. This was something actually the hospitals were pushing, obviously, and all radiologists except the IRs have been pulled from the hospitals. And we've given, just as the others had mentioned, some priorities to the older radiologists, or even to some of the radiologists who have kids with special needs, in order to minimize the exposure. So the greatest exposure within the group is certainly within the IRs, including our PAs, which are in the hospital with us. One of the things that really kind of drove us during this time and helped us was the fact that we had a robust telerad service prior to this, and we had our own full service IT section with some very talented IT guys who are employed by the group, and this has allowed for continued subspecialization, including MSK and neuro. And then one of the things that they allowed us to do was to consolidate the reading chairs. So initially, we got rid of one chair, and then there was further reorganization because after the first couple of days, it was a little disorganized as far as with the new chairs, who was reading what. So very important was to reorganize the chairs and define the chairs such that everybody knew their roles throughout the day. One thing that we had already implemented and started was the deployment of home workstations for all radiologists. We had planned on doing this over a period of time, and this has been accelerated by the response to the COVID pandemic. Next slide. Next slide. So our initial reaction, you can hit next slide and it'll pop up, was prayer for rescheduling process and implementation. Fortunately, we work with a group of hospitals and facilities that are amazing, and we were able to quickly get to them on a administrative level and work through what is medically emergent versus medically urgent or non-emergent, in addition to guidance from guidelines that have been put out by the ACR and the SIR. I would say in general, all non-emergent cases and imaging have been deferred until May, just as previously described. Screening exams were all canceled and are in the process of being rescheduled, including mammo screens, lung cancer screening, and calcium scores. We're still doing some diagnostic breast, but obviously no screens. From an IR standpoint, the case volumes have declined, but in general, they have actually remained fairly steady. We have a fairly robust interventional oncology service, and we've worked very closely with the oncologist in trying to figure out, what can be deferred and what have you. But it's certainly a gray area. The oncology workups and treatments have proceeded with some modifications, and some of the biggest adjustments actually are on the patient side, where a lot of the hospitals, they will not allow family members to come in with the patient. So it's very important that we consults and those type of things, the clinic, all those things have been modified to have some component of either phone consults or telemedicine type consults, but giving them instructions as far as what they're to expect once they get in the hospital is very important, such that they kind of know exactly what's going on before they get here, because it's certainly different than our norm. We too are expecting to have a large backlog of IR cases and even MSK cases post-COVID, but this is certainly an unknown. Part of the unknown is really kind of trying to understand what things are going to look like down the road, because there have been lots of patients and individuals who have lost their job, possibly their insurance, and imaging is not insignificant. And with copays and different things, they may not have the money to pay for such. So that'll be something that we're going to be having to work with the hospitals very closely with, and work with the patients as well. Next slide. Accommodating downstream increased demand in COVID-19 after COVID. The initial reaction of the group was panic and chaos. I say that, but actually our group was fairly well positioned for this, and it is tricky, but we're maintaining our current level of radiologists. I think overall, for the last year or so, we've probably been understaffed and overworked for the most part. So this is really kind of an adjustment down, and kind of even getting some work-life balance, as we previously discussed here. Future hiring is kind of up in the air, just because it's really hard to predict with certainty the future volume and revenue. This is further complicated by the hiring atmosphere, which even before the COVID, when you're looking at candidates and what have you, they are in the driver's seat, and this probably will continue post-COVID. And so for the hires that we've had and we've already signed, we certainly are going to do everything we can to keep them, and we want to make sure that even if it means a decreased revenue for partners, we don't want to miss out on good candidates, for a short-sighted approach. From the group, we are forcing some vacation for the partners and random days off. We call them RDOs, similar to the flex days that were described, but plan to respond to future demands as they arise, just as they said before, likely related to either decreased vacation or increased compensation, or both, likely both. The last thing was, next slide, managing decreased revenue due to COVID. The initial reaction to the group was really more panic, leading to group infighting. We got through this, and we're doing fine now, but the initial projections were up to 40%, which is fairly catastrophic to a lot of groups, before there was information about loans and what have you. I think as a group, we're probably planning for about 20% reduction in revenue for 2020. It's really hard to know based on the numbers that we've seen within our system the last couple weeks. Hopefully it's going to be less than that, but it's really hard to determine that. We are, as a group, preparing weekly cash flow and work projections to determine scheduling. That's very important because it may change on a weekly basis. And we do have holidays coming up, there's different things so we have to be able to adjust on the fly. We did apply, and we just got accepted for a SBA or PPP loan. We also are looking into state loans, bank credit lines, and even the possibility of malpractice insurance deferral, which may be a possibility for some groups, depending on who you're working with. The accelerated payments for Medicare, we looked at that, and you can potentially get a 3-month advance for private groups. We as a group don't feel this was the best option for us, but it's another potential option. One thing that we did do was initial was a 15% reduction in salaried employees pending the loans. The goal is, once the loans are captured, to make the employees whole at that time and pay them back for the full amount that were reduced during the time period. From a partner standpoint, we have reduced partner payroll and bonuses until further notice at this point. And just like one of the other speakers was saying, we're also trying to minimize the use of independent contracted radiologists as much as possible. Thank you so much.
Dr. Kirsch, thank you for your presentation. Our next speaker is Dr. Moe Sabasha, Vice Chair of Clinical Operations at the University of Washington. Dr. Moe Sabasha.
Thank you for the introduction, Dr. Carlos. So I'm coming to you from University of Washington, an academic practice that consists of 6 hospitals and 4 outpatient imaging centers across Western Washington. And Washington State was the initial site of outbreak of COVID-19 in the US. So we had a bit of a head start in relation to policies and for COVID preparedness. In addition, according to the modeling done by University of Washington's IHME group, we've already hit our peak. We hit our peak April 2nd. So we'll also be in the process of planning the recovery phase before a lot of other parts of the country will be. We consist of 150 faculty, and we are a salaried employed group. Next slide. So in terms of workforce deployment, or redeployment, I should say, we submitted to the dean a list of faculty that can cover surge-sensitive areas. And for radiology specifically, we targeted emergency department and acute care units with guidance. We indicated to the dean that we could operate with guidance. And this specifically means basically at an intern type level, our faculty and trainees could operate. And in terms of the people we listed all faculty that were not at increased risk of infection and poor outcomes based on risk. These were all the faculty that we included. Similarly, our residency leadership put together a list of trainees that could be redeployed. And so far, we have not had any radiologists redeployed. There has been a request from GME for redeployment of 30 trainees across our system, but these will be prioritized to other residency groups, specifically like family medicine. And we feel the likelihood of radiologists being redeployed with the current setting to be pretty low based on that modeling indicating that we've already hit our peak. Now, in terms of radiology at our site, we've had a couple different efforts in terms of coverage that we've modified, similar to what some of the other speakers have talked about. For some sections, we split the teams, split their section into teams for coverage where these radiologists work exclusively together in the reading room in order to minimize exposure across the radiology section and to maintain coverage if there is infection within the group. In addition, we've established 21 single workstation radiology reading rooms across our enterprise where radiologists can work in isolation. We have homework capability where on any given day, multiple radiologists are working from home. In addition, in our reading rooms, we've employed what we term extreme social distancing, where we have one faculty, one fellow, and one resident in the reading room, spaced across multiple workstations in fairly large reading rooms. So in terms of the elective exam rescheduling, first in terms of screening exams, we've postponed all screening exams, lung screening, mammographic screening, and virtual colonoscopy, as well as DEXA scans. And these have been delayed through the beginning of May with every 2-week reassessment to determine whether we have to postpone even more. In terms of the rest of our elective imaging exams, we've employed our automated text messaging system to communicate with patients the recommendation to reschedule outpatient elective exams. We indicate to patients through this text messaging system that they should communicate with their physicians to determine the urgency of their exams, and we also provide them with the rescheduling phone line. And the reason we feel the need to engage patients and the ordering physicians in this process is because they're much more in tune with the patient presentation and symptomatology and the urgency of that exam, as opposed to our ability to determine that based on a brief history and the exam ordered. In addition, for new exam orders, we have requested that ordering physicians place in the indication box the time sensitivity of the study and the urgency and the time frame in which imaging needs to be completed. So they could indicate that it's critical and this exam needs to be done immediately. They could indicate it's urgent and it needs to be done within the next week, 2 weeks, 3 weeks, or we can indicate that it's non-urgent and it can wait till after the postponement period. And in terms of the elective imaging, currently our target is May 18th for the postponement, but that obviously is also something that can be modified depending on how it looks on the ground. So in terms of downstream increased demand after COVID-19, the post-COVID-19 surge that's expected, we're looking at increased operational coverage. We are preparing to have scanners run on weekends and late into evenings, and also maximizing scheduling and resource utilization at our outpatient imaging centers. We have been looking at accelerating our imaging protocols in order to facilitate that imaging. In addition, for our staff and our faculty, we are urging them, if they want to take paid time off right now to spend time with their kids that aren't in school, or if they're concerned about potential exposures, this is a good time to use that resource to prepare for the increased volumes that we're anticipating are going to come in the future. And similarly for faculty, use academic time, use vacation time now. We're reducing faculty coverage in the reading room. And the other advantage is there is the potential, as these surges happen, that we may have to upstaff the reading rooms so that and that may result in limitations on vacation time in the summer. And in terms of managing the decreased revenue, it's estimated for our system between the various hospitals that it'll be a total radiology volume drop of 39 to 60%, with a drop in outpatient volume of 55 to 70%. during this COVID-related rescheduling. And so there are two different components in terms of mitigation of this: cost reduction and increased revenue plans. Now, our overall goal is to maintain our academic mission while also protecting faculty salaries and FTEs. And so the initial portion is cost reduction for short-term stabilization of our operations. And these are things that we are exploring and considering depending on the financial need. And we are seeking buy-in from our faculty for the approaches that we take. We don't intend on doing all these things, but these are things that we are considering. First is deferment of faculty incentive payments, and we're looking at deferring maybe 75% of that faculty incentive. In addition, reduction or elimination of temporary supplemental payments for excess shifts, and we're looking at consolidating our coverage to where those remote sites are covered centrally during all hours to eliminate that TPS payment, as well as to eliminate some of the teleradiology payments we have. We're looking at a hiring freeze for 6 months, reduction of faculty educational allowance and section discretionary funds, consolidation of our support staff, consolidation of graduation events, and looking at cheaper alternatives for venues, as well as shutting down of inefficient research cost centers such as our radiochemistry lab. And then the other side of it is the revenue generation side that we plan as a long-term solution. Now, these are things we were already considering, but the COVID-19 outbreak has certainly accelerated our efforts in this space and our timelines. And we're looking at increased efforts in teleradiology contracts, increased contract research organization work, implementation of standalone outpatient imaging centers with revenue sharing models, as well as additional revenue diversification models that are currently in the planning phase. In addition, as I mentioned, increased efficiency on our imaging side, which will both improve our post-COVID workflows, but also increase revenue, such as shortened block times in MR, shortening the scan times in CT, and really improving those imaging efficiencies. Thank you.
Thank you, Dr. Moe Sabasha. Our next speaker is Dr. Michael Recht, Chair at NYU Langone Health Systems. Dr. Recht, please say next to move to the next slide. Thank you. Dr. Recht.
Hi, can you hear me at this point?
Yes, we can.
Perfect, sorry. I was just saying thank you. I practice at NYU Langone. We are a faculty group practice at an academic center. We have 5 hospitals. We have several outpatient imaging centers. We currently have approximately 230 faculty radiologists. Next slide. In terms of what we were doing, it's similar to what other people have said. We had approximately a quarter of our faculty who had home workstations prior to COVID preparation starting. We quickly added additional just under 100 workstations to the majority of our faculty. We didn't give it out right now to our breast imagers, as they can't really work from home with mammography, and we're not doing screening mammography. Most of our radiologists are reading remotely on each day. We only have an on-site skeleton staff, both at our imaging centers that are open as well as at our hospitals. In terms of redeployment, our experience has been slightly different from others. We have had redeployment. First, we had our IR team going up to bedside IR services. And that's been something that's been very well received by our hospitalists and intensivists. They're doing several central lines a day. They do a lot of dialysis catheters. Very little thoracentesis, but they can do that. Many of our other radiologists, because like everybody else who has talked, our volume is significantly lower than it used to be. And because we have such a large outpatient part of our practice, we have a lot of radiologists with significant downtime. So they volunteered for a lot of other activities that are ancillary, not right on the floor. We've done some virtual employee screening for patients who think they might be COVID positive or need to have testing. One of the largest activities we've been doing is something called NYU Family Connect. And this is a project that started because, like many of you, we have a no visitor policy in the hospital. And that means not only are the patients alone, but patients' families really have no way of finding out what's going on with their loved ones. And people on the floors don't have a lot of time to take the time to talk to patients' families. So what we're doing is we actually have 67 of our radiologists who volunteered to be part of this program. They're working with medical students. They attend virtual rounds for each of our units in the hospital. They're learning what's going on with the patients. They've adopted families. So each radiologist has about 8 patients and families that they're responsible for with the medical student. They then go through the chart. And every day, and this is a 7-day-a-week event, they're calling the patients' families, communicating what's going on with the patients, and trying to answer some of their questions. And that's something that's been very meaningful for our radiologists, as they feel that they're connecting and really working during this crisis. We've also had some faculty volunteer to be redeployed to our floors who feel comfortable doing that. In terms of our house staff, we've had about half of our residency group, and we have about 40 residents have volunteered. As of today, all of our volunteers have actually been put on services at one of our hospitals. Again, there's a pyramid system on the floor, so none of these people are doing things that they're not comfortable doing. They have people who are in medicine or ICUs who are the main people, but they're acting as interns/externs on these floors. Our staff has been very, very helpful, and I really want to mention that our staff has really stepped up. I'm sure other staff has as well, because we have such a large outpatient staff, and because our outpatient volume is so low, we've consolidated hours and we've closed several of our sites. And all of those staff have been retrained and going back into the hospital. So several of them are working for portable radiography. As you heard before, there's an increased demand for portables. We've got extra portable machines. So if you haven't had the surge yet, that's one of the things I would have you think about if you're taking care of a hospital, making sure you have enough portable equipment to take care of the demand. But we've retrained our staff from the outpatient centers. We have a list of outpatient staff who are filling in for our hospital staff when they need to call out. Some of them are getting sick and are quarantined. And the rest of our staff are placed in a labor pool, and they've all been redeployed, sometimes in building services, some in supply chain, some as nurses' aides, and they've really stepped up to do that. And I think that's something that we really have to remember and think about, because how useful they have been. Next, please. In terms of elective exam rescheduling, it's very similar to what you've heard before, so I won't spend a lot of time on it. Our first phase was we scheduled all of our screening exams, lung cancer screening, screening mammographies. We started doing that at 2-week blocks at a time. We were very optimistic. When we rescheduled for June. We've now blocked all of our screening as well as elective exams out to May, and we've consolidated a lot of our hours. Our second phase was we eliminated all elective exams at our outpatient centers, MR, CTs, ultrasounds. In all honesty, that wasn't hard because most patients were canceling on their own. We've, again, started scheduling elective exams only into May. And again, we've closed several sites and consolidated hours even further. Next slide. This is something I just want to mention. As an academic center, research was something that we had to think about. We had multiple phases. I won't spend a lot of time on it, but initially we canceled all of our human research exams. We checked the helium levels on all our MR scanners. That's something that we learned 8 years ago when we dealt with Superstorm Sandy, and we lost some of our sites. And we tasked all of our managers to prepare contingency plans where they could work with minimal or no staff. We really looked at sharing centralized telework services for all of our teams. All of our research teams are working remotely. Communication is something people have talked about before that is key during a crisis like this. We have weekly WebEx town halls for research, virtual coffee hours, social networking. we do very similar things for our faculty and staff. I've hosted several virtual town halls for each group of people answering their questions, and I think that really gives them a sense that there is a community and engagement, because it's hard when you're working from home. And finally, in research, we've really talked about trying to beat COVID-19, working on AI, as well as a lot of 3D printing of face shields. And that's something else I would tell you if you haven't seen the surge yet. When you're thinking about PPE, if you have 3D printing capability, think about doing that. Next slide, please. Education is something we haven't talked a lot about, but for academic centers, like some others, we've limited the number of residents per attending and reading room to make sure that we have social distancing. We created several new reading rooms to allow us to maintain social distancing. One of the projects we're working on is simulated daily work lists. Several of our residents are going to be losing months of residency because we don't anticipate outpatient volume picking up quite as fast as maybe some others who are more optimistic. We think it's going to be a couple of months. And what we're doing is using old cases, pulling them back up, de-identifying them, and creating daily work lists to simulate what a resident would see. And in fact, we think that might be better because we can actually control the cases and make sure that they're standard cases and they're seeing everything that you need to see depending on your residency level. All of our conferences are done remotely. We've released the AUR residency core curriculum through a strategic alignment grant. Each of our sections is working on educational and research projects, so we have a lot of downtime, but we're creating teaching files. One of our sections created 200 teaching files last week alone. We're doing RAD pass cases for our medical students, and really working on increasing our education, even though our volume is down. Next slide. In terms of accommodating downstream increased demand, this is something that I must say feel a little differently than some of our previous speakers. We do think that there's going to be increased demand at some point. I don't know that we're going to have a V-shaped recovery. Until we get a vaccine or some type of effective antiviral agent, I think people are still going to be worried about social distancing. So what we're looking at is how we're going to image in the future. What is our outpatient imaging going to look like? I don't think our waiting rooms are ever going to look like they did before in terms of the crowded waiting rooms that we had. So we have project improvements. We have about 50 or 60 people on our team who are looking at what we're going to do post-COVID. We're looking at how we're going to schedule. Are we going to stagger? Are we going to have increased hours? Up till now, we've done everything we can to be increasing our efficiency and productivity. We're down to 15 and 20-minute MR slots. We don't think that's going to work anymore until we get these effective vaccinations. So we're saying, how are we going to make them longer? We're working on our order sets to make them simpler. We're working on protocol optimization. We're going to think about using a lot more online scheduling and screening. So when patients come in, they won't be in the waiting room. Everything will be done beforehand. And again, we're working on hours of operations and talking about how we're going to need to increase some of those hours of operation to meet the demand and gain back some of the revenue that we're losing. Next slide. In terms of decreased revenue, we are seeing huge amounts of decreased revenue. I guess we're somewhat protected because we are part of a faculty group practice, so we're salaried employees. We have not seen any salary decreases for any member of our team, our staff, nor our faculty. There's been no layoffs and no furloughs. We have eliminated all overtime and moonlighting, both in our staff as well as with our radiologists and our residents. And one thing that has happened is our capital projects have been put on hold. We don't know how long that's going to be, hopefully not too long. But right now we know there's going to be delay in some of our capital equipment purchasing. Thank you.
Thank you, Dr. Recht. Our final speaker is Dr. Geraldine McGinty, Chair of the American College of Radiology. Dr. McGinty.
Thank you, Ruth, and thanks everyone for sharing your stories tonight. I'm going to be very brief, just to say that our ACR is working hard to make sure that we support our community wherever you practice. Next slide. And we have created a COVID-19 specific landing page, next slide, where you will find multiple resources, whether it's guidance around rescheduling routine exams, whether it's educational resources. We've made resident educational resources available through our continuous professional improvement modules. There's also a member-only page which has a lot of guidance on the various financial relief opportunities that are coming out of Congress. And please rest assured that even as I'm listening to everyone, I'm getting emails from our government relations team who continue to work with Congress on how to make sure that whatever relief package comes out is beneficial for us in radiology. So I'm going to stop there, but please keep an eye on that page. We update it constantly, and really thank you everyone for sharing your stories.
Thank you. We are now at the top of the hour, and I wanted to thank all of the speakers for sharing their experiences and their hard-won knowledge, and for their candor and frankness and honesty is appreciated during these times. Thank you to the participants, and I would like to draw your attention to another webinar opportunity, the RLI Leadership Town Hall, Leading in Times of Crisis, Thursday, April 16 at 7 p.m. Eastern. This adjourns our JCR-sponsored webinar. Thank you.